Good morning, everybody. It's Wednesday, July 28th. We're back with more COVID news, and I'm just going to dive right into some of the data I've seen. So, Gary, this morning I saw a graph, and I see we're getting an uptick in cases, and the graph, they were like bookends to a year to the day. We're having a parallel bump wrapped around this big winter surge. What's going on now?
So this is actually a different thing from last year. Right now we're seeing a Delta surge, and this is a surge of unvaccinated people. So it's kind of tragic. People who are choosing or haven't got vaccinated yet are really vulnerable to a much more transmissible virus with the Delta virus. We know it's more transmissible than the UK strain, the Alpha strain, and probably more virulent. And so this is clearly a surge of unvaccinated people. 99% of people in the hospital right now are unvaccinated from this virus. So let me kind of bring everyone up to speed with a couple of graphs. I think these are very illustrative. The first one is actually a map of the US. The first one's a map of the US that shows the hot spots. And red is hot, and you can see the Southwest is a problem. A little bit of the West, but California is kind of mixed. So there's some hot spots here and not some hot spots because California is more vaccinated than the rest of the country, which is really good news. The next slide is a little bit busy, but I'm going to kind of walk you through it. Each of these columns represents a week showing what different variants are there. And so if you look at the very light orange or the pale orange at the very top, that's the Alpha strain, and that's back in April. So in April, most of what was in the US was the Alpha strain, and very, very small down there, not the orange, but the dark orange line, that was the Delta strain in April. Now move to the right here, and you'll see where I've put a black box in. That's actually July data. July data shows that the Alpha strain is very small in the US and that the Delta strain is now actually 83%.
Wow.
In Sonoma County, way over 90%. 90% or more of the strain matching is in the Delta variant in Sonoma County and probably in California as well.
We knew this was coming. I remember them talking that in March maybe it would hit us, but it's fully here now.
Right, and it happened just to overlap exactly with last year.
Yeah.
So the next slide I'm going to show you comes from the New York Times. I found this just to be fascinating. Let me just kind of orient to this graph. The vertical is the percentage of people hospitalized, 10, 20, 30% of hospitalization rates. And to the right on the horizontal line, that's the percent vaccinated. And as you can see, places like Louisiana, Nevada, Florida, huge hospitalization rates, sometimes above 30%, and an unvaccinated population. If you move to the right, the more vaccinated you get, the lower your hospitalization rate goes. And so you can see California is sort of towards the right of that curve with about probably 7% hospitalization of cases who are positive for COVID. So I think this is really instrumental that this is an unvaccinated surge with this new Delta strain. And then I'll just show you kind of what looks like locally on the next slide. This is actually what we get in the center footprint. And as you can see to the right, that's the bump with the Delta variant in the unvaccinated cohort. So it's different from last year because last year we were kind of fumbling in the dark. Last year we were fumbling in the dark, wondering which PPE worked, which PPE didn't work. Are we being too conservative, too strict? And we didn't have any treatments. We were waiting for vaccine trials to come out. Now we have vaccine readily available, the two best vaccines in the world, and we know much more about what we're doing in the hospital. So, and we also know that PPE works now.
You know, and I just referencing back that last graph, and we see the big spike going up there. But we must have a different demographic. I don't know that we've measured it, but in our population, I took the time this morning to call Sutter Shared Lab and check with them because we're all screening these patients in our offices if they're symptomatic. And in the first 3 weeks of July, July 2, I believe it was July 23, we only had 5 positive cases gathered throughout all of our care centers. So wouldn't really reflect what we're seeing here. So fortunately, we're not seeing a lot in our patients at this point.
Yeah.
So Gary, so it's out there now, and it's all a Delta virus, which you know is very contagious. And in all likelihood, we're all getting exposed. We may not know about it, but when you're passing through Costco or getting gas or something, we're probably getting exposed. But our real concern is how do we avoid an exposure? I'm talking about with a capital E, a high-risk clinical exposure, which is what we're concerned about because we're seeing patients now in our offices. So can you remind us what the definition of that is?
So I think you're right. First of all, we're getting exposed all the time. I think it's very likely you're getting exposed in the community. You're getting exposed at the grocery store. You're getting exposed in your neighborhood much more than at work. Because at work, we're still mandating masks. And pretty soon, we're going to come out with Sutter Bay Wide and SHEMS is going to recommend face shields again.
Okay.
And so the workplace has been a much more safer area, but I think even at work, there's a potential to be exposed. And so we actually categorize the exposure risk as low, medium, and high risk.
Okay.
High risk exposure is very important. High risk exposure is you're in a closed setting inside a room for within 6 feet of someone for more than 15 minutes with either no PPE or incomplete personal protective equipment. And so that's very important. So again, I'll just say high risk exposure is you're within 6 feet of someone for more than 15 minutes with incomplete or no PPE.
When you say incomplete, I would imagine that the mask is the most important thing. So let's say someone who's not wearing a gown, would that be a lesser exposure than somebody who's not wearing a mask?
Yeah, the mask is absolutely fundamental.
That's the critical. Okay.
That's fundamental. So if it might be helpful, let's do a couple scenarios.
Okay.
And I'll also just say, because we're getting exposed, that's why we're wearing face masks. And that's why the CDC is going back to that, even in vaccinated people.
Okay.
And that's why we're thinking about face shields, and that's why we're vaccinated. So let's give two scenarios. So I'm kind of thinking, if I'm in the clinic, this is scenario one. Middle-aged male, seen in the clinic because he twisted his ankle. Now, if the physician comes in wearing a regular surgical mask and soon a face shield, and he enters a room and he notices the patient is sneezing and coughing. So obviously, this is a potential PUI. This is a person under investigation who may have COVID because they have URI symptoms. So the question is this a high-risk exposure when you walk in the room? And the answer is no, it's not a high-risk exposure. Because you are wearing a surgical mask, but not an N95, but you're in that room, not to 6 feet yet, in less than 15 minutes. So it's not a high-risk exposure. We don't need to do anything. You simply leave the room, put on the appropriate PPE, and then you enter the room. So that's the first scenario. So the second scenario is a little bit different, and I think this can happen sometimes. So middle-aged person comes into the clinic. They're seen for, let's just say, diabetes management. No symptoms whatsoever, but this person asks the physician, they're going to be traveling internationally, and can they get a COVID test so they can get on an airline? The physician, wearing a regular surgical mask and soon a face shield, but not an N95, takes an NP swab, does COVID testing. Let's say the visit lasts for 17 minutes, 20 minutes, beyond the 15-minute time frame. Then they found out the NP swab comes back positive. So what you had in the clinic was an asymptomatic person who didn't know they were positive, and they were NP swab positive. Is that a high-risk exposure? And if you follow our guidelines, it isn't. It's a moderate risk exposure, not a high risk exposure. So in a vaccinated healthcare worker who took care of someone with incomplete PPE for more than 15 minutes within 6 feet, what do? If you have no symptoms as a healthcare worker and you're vaccinated, you come back to work, we swab you once and we repeat that swab in 5 to 7 days. And it's business as usual. So again, less than 6 feet, more than 15 minutes, with incomplete PPE puts us at a high risk exposure for someone who's known to be COVID positive or symptomatic and a PUI.
Okay. So I hear what you're saying. We still need to do full PPE for clinical care.
Right.
Yeah. And it'd be nice if we could just demonstrate what that means, what that looks like.
So this is it, Gary. Yeah. This is full PPE. A gown, gloves, a face shield, and an N95 mask. And the most important thing here is the N95 mask. This is 90% of the protection.
Yeah.
And so if you see a patient who you suspect having COVID, or they have overlapping symptoms, you want to be wearing this full PPE in the clinic room.
And this is what has been proven to be effective. Like, this is why we aren't seeing iatrogenic disease in the ICU and the hospital and in our clinics.
That's right.
We feel comfortable with this. Other than the fact that you steam up very quickly.
And it's very hot.
Yeah. All right, welcome back. So let's talk a little bit about management. So you are seeing these people in the office, and let's talk about how to manage mild illness. So we've got the first slide here that shows you some of the general principles. This is a viral illness, folks. You've been treating viral illnesses for a long time. There really is no treatment other than what we're going to talk about shortly, but it's conservative care. I think you, as it says, watch for secondary infections. There's some important issues down below. and that we have learned from the data and from the different guidelines out there that really the key message is what is a patient's O2 sat, what's their general condition, and then take into consideration their comorbidities and their age. I mean, that's really what it comes down to. And this is a good point here. If you're concerned about somebody who has some comorbidities and age, consider sending them home with an O2 sat, or send them to Walmart to get when you get them on Amazon. It's very easy to obtain a home oxygen saturation monitor.
You know, Gary, something to comment about is that the Delta strain seems to have more headache with it. And so we're adding headache back to the screening questions.
Okay.
And also Sean made a good observation early on in the pandemic. He noticed that some people had low oxygen saturations and they weren't that dyspneic. So there is this element of silent hypoxia. So the vital signs are really key: respiratory rate, temperature, heart rate. But the O2 sat is very important when you're seeing patients who you think might have COVID. You don't be surprised if once in a while you find someone with a lower O2 sat and they don't really recognize it.
And I think that if you want specific numbers, I think the criterion that has been established and used in our respiratory clinic was a sat lower than 94.
Right.
So anything above that you can feel comfortable with. Lower than 94 is a little bit of alarm. They may not be symptomatic, but that's something to consider.
Yeah, and I must say that Sean's very evidence-based. We didn't pull that out of the hat.
Yeah.
Those are national guidelines for 94%.
Okay. So Gary, let's talk about the only treatment we have from the ambulatory side. So what are the criteria for us ordering or including monoclonal antibodies?
So there's one effective outpatient treatment and really one effective treatment only. And there's been a lot of talk and chatter about some other treatments, and I sent out that email about ivermectin and it's all over the place. So please don't use it. But the best thing right now is this Regeneron monoclonal antibody. And it's not really a monoclonal antibody. It's two monoclonal antibodies put together, Casavirumab and Indevimab. So these two monoclonal antibodies are put together in an infusion. So if you have someone in the clinic and they have mild disease, but they're not hypoxic yet. They have mild disease or not hypoxic, but you're worried about them because they're in a high-risk group. You can send them to our ED where they're going to get monoclonal antibody. Now, Sutter made the decision that we're only going to give monoclonal antibody in our emergency rooms. So it's a Sutter-wide decision, not in the infusion centers, but in the ED. Age over 65 is a comorbid condition. A BMI over 30 is a comorbid condition. Diabetes, coronary disease, hypertension, chronic lung disease, immunocompromised disease or immunocompromised therapy would be considered a high-risk situation for someone to get it. Now, the reason why we don't use monoclonal antibody in people who are hypoxic, because if you're hypoxic, you're going to send them to the ED anyway. They're going to get convalescent plasma and they're going to get remdesivir. So they're going to be put into an inpatient treatment side. So patients who go to the ED who are hypoxic get admitted. People who go to the ED that are not hypoxic will go home, often with a pulse oximeter from the ED, but now we're going to add this treatment strategy in there of Regeneron or this dual monoclonal antibody therapy.
So if you think about how this works, you're seeing a patient, if they're hypoxic, then game over, you're going to send them to emergency room. But otherwise, you've made your clinical evaluation, they're stable, they may have some comorbidities, they look okay, you send them home. It's only the next day when you receive a positive COVID test that the issue of, all right, let's review the comorbidities. Maybe this patient should be referred to the emergency room at that time.
Right, and we've done that a few times where I've got calls that I have a really, brittle diabetic, or I have someone with, unstable angina, or someone with chronic heart failure. Certainly that's a patient I would consider. Now, I think we have not been using enough monoclonal antibody, and I think that's something that's underutilized, and there's a big push nationally from the Infectious Disease Society of America, from the CDC, from the NIH, saying we need to use more monoclonal antibody. And I think that'll be a game changer for people not coming into the hospital and not having the hospital surge, even though our case rates might go up.
Okay, so just to be clear, you refer them to emergency room, they get their infusion, they go home.
That's right.
Okay, all right. Well, I hope this has been helpful today. It's always a moving target. Please, again, feel free to reach out to us with any questions you have about these topics, and enjoy your day.